Good morning, one and all. My title is Healing Against the Odds, Hydrops After DALK. As we all know, keratoconus is a progressive primary corneal ectasia. Acute corneal hydrops occurs in advanced keratoconus due to break in the descendant membrane and aqueous intrusion resulting in a stromal edema. DALK is the preferred surgery for advanced keratoconus, preserving the patient's endothelium. Corneal hydrops post DALK is extremely rare, with most cases requiring further surgical intervention. So here I am presenting a case of 10-year-old boy with bilateral keratoconus with progression in left eye after corneal collagen cross-linking. So patient underwent manual DALK in left eye. Surgery was uneventful and post-operative visual acuity was 612 following suture removal. Patient presented a year later with a decrease in vision in left eye of 1 week duration post history of vigorous eye rubbing. Visual acuity was hand movement plus PL plus PR accurate. On examination, we noted conjunctival congestion, corneal graft showed microcystic and stromal edema with detached descendant membrane involving the central and inferior cornea with a relatively clear cornea in superiotemporal periphery. Intraocular pressure was 24 millimeters of mercury. We started him on lotiprate eye drops 4 times a day, timolol 0.5% eye drops 2 times a day, and 1% atropine eye drops once a day. On 8th day, vision was improved to 5/60 and intraocular pressure was 18 millimeters of mercury. On examination, there was reduction in stromal edema and spontaneous reattachment of the descendant membrane with the fibrosis more evident in inferior quadrant. After 2 months, best corrected visual acuity was 618 with stromal scarring and inferiorly fibrous descendant membrane. What is unique in my case? Only one case of acute corneal hydrops 52 months post big bubble DALK surgery has been reported so far. Corneal hydrops post keratoplasty differs from that in the advanced keratoconus in that it is typically starts at the graft host junction, most commonly in inferior cornea. Conventionally, these cases require surgical management for descendant membrane reattachment. However, in our case, there was good anatomical and visual outcomes with conservative management. Clinical implication: acute hydrops post DALK is a rare phenomenon, with eye rubbing being the most common inciting factor. The retained keratocytes from manual dissection could also be factor involved in disease recurrence. Our case highlights the importance of preventing eye rubbing and IOP spikes in a patients with successful DALK surgeries to prevent disease progression and complication. Thank you.
Thank you. And are there any evidence to prevent IOP spikes, to prevent hydrops?
Sorry, sir.
Your last message was like avoid eye rubbing and IOP spikes.
Yes, sir.
So is it based on any previous studies or?
His
See, eye rubbing is definitely associated with
Yes.
hydrops, but what about IOP spikes?
His intraocular pressure was 24 millimeters of mercury. So we assume because of raised intraocular pressure, that can also be the one cause for hydro.
Maybe,
Unlikely.
but
Maybe following LASIK, no, what we used to see that
yes,
subflap, the fluid.
After LASIK, yes.
but there is no evidence that suggests spikes in IOP can lead to hydrops.
Yes.
If somebody asks you, your answer should be yes. Trauma in form of eye rubbing or any trauma can precipitate hydrops, but IOP spikes may be there may be two associated but not causal factor, right?
Yes.
So that is to remember.